The appointment lasted 11 minutes. Sandra was 71 years old. She had been noticing increasing difficulty with her central vision for about 8 months, and she had finally gone in to find out what was happening. She had been putting it off, the way many people do, telling herself it was probably nothing, that her glasses just needed updating, that it would resolve on its own. But the soft blur that appeared near the center of her visual field when she tried to read had not resolved. It had grown slowly but unmistakably more present over those 8 months, and she had finally made the appointment. The ophthalmologist was not unkind. He was direct. He told her that her retinal imaging showed the kind of changes that typically progress toward neovascular AMD, that there were early signs of abnormal blood vessel growth beneath her macula, and that if the progression continued at the current rate, she would likely need intravitreal injections, a procedure where medication is administered directly into the eye to stop the vessel growth, to prevent further vision loss. He told her to come back in 3 months and they would reassess. He was not dismissive. He was doing his job thoroughly and correctly within the time and tools available to him. She left the office with a pamphlet and a follow-up appointment, and no one had said a single word to her about what she was eating. Sandra found her way to my practice through a referral from a friend who had been a patient of mine for several years. When she called to make the appointment, she told the receptionist she was not sure what she was looking for. She just knew that the conversation she had had with her ophthalmologist had left her feeling like there was nothing she could do except wait and watch her vision decline until an injection became necessary. That feeling, the sense of passivity in the face of something frightening, is one of the most common things I encounter in patients with early macular disease. And it is one of the things I most want to change. The first thing I did when she sat down in my office was what I do with every patient who comes in with a macular concern. I asked her to walk me through a typical week of eating. Not her best week, not the week she was trying, a representative, honest week. And what she described was not unusual for a woman her age in the United States. It was a diet that, by most conventional standards, looked completely fine. She was not eating fast food every day. She was not consuming excessive sugar by most people's measure. She was cooking at home regularly. But it was a diet almost entirely devoid of the specific nutrients that the macula depends on most, and rich in the inflammatory inputs that the research increasingly links to the vascular changes occurring at the back of her eye. I want to tell you what changed, why it worked from a biological standpoint, and what happened when she went back to her ophthalmologist 3 months later. But first, I need to be clear about something, and I want you to hear this carefully. I am not telling you that dietary changes replace medical care for advanced or progressing eye disease. Sandra's case was caught early. Her changes were made under medical supervision, and she continued her scheduled follow-up care throughout. Diet is not a substitute for the clinical management of serious retinal conditions. What it is, and what the research increasingly supports, is a powerful and underutilized component of that management, one that most patients are never offered in the 11 minutes their ophthalmologist has available. Everything I share here is educational. It is not personalized medical advice. If you have concerns about your eye health, please see a licensed ophthalmologist. Now let me tell you Sandra's story. The first thing I changed was the fat she was cooking with. Sandra, like the majority of American home cooks, had been using a generic vegetable oil blend for most of her cooking. Soybean and canola-based, refined, high in omega-6 linoleic acid. Research published in the American Journal of Clinical Nutrition, drawing from the age-related eye disease study cohort, found that higher linoleic acid intake was independently associated with increased risk of advanced AMD. Independently, meaning the association held even after controlling for other dietary and lifestyle variables. The oil itself appeared to be the contributing factor. I asked Sandra to replace it entirely with extra virgin olive oil for moderate heat cooking and avocado oil for higher temperatures. That was the first change, one swap. The second change was the most significant, and it is the one most people never make because no one explains why it matters. Sandra was eating almost no foods with meaningful zeaxanthin content. Her diet was low in leafy greens generally, but the specific gap was zeaxanthin, the carotenoid that concentrates preferentially in the foveal center of the macula and functions there as the primary optical filter and antioxidant shield. Research published in Experimental Eye Research has documented that zeaxanthin accounts for approximately 75% of the carotenoid content in the foveal center. It is the dominant protective pigment at the precise zone of the retina where early neovascular changes most commonly originate. And Sandra was barely consuming any of it. I introduced 3 specific foods. Orange bell pepper, which is one of the most concentrated zeaxanthin sources available in any standard grocery store. Egg yolk, consumed as 2 whole soft-cooked eggs each morning, specifically for the lipid matrix that makes the zeaxanthin and lutein in egg yolk approximately 3 times more bioavailable than the same compounds from plant sources, as documented in research published in the Journal of Nutrition. And goji berries, 2 tablespoons soaked and consumed daily, because goji berries contain zeaxanthin at concentrations that rival almost any food currently documented in the nutritional science literature. A 2021 study published in Nutrients followed adults aged 60 to 80 consuming a small daily serving of goji berries 5 days per week for 90 days, and found significant increases in macular pigment optical density and, critically, no progression of existing macular changes in any participant during the trial period. The third change was addressing the chronic, low-grade inflammation that the imaging suggested was contributing to the vascular instability at the back of Sandra's eye. This is the part of the conversation that most nutrition discussions about eye health skip over, because it requires understanding a mechanism beyond the macula itself. Neovascular AMD, the form Sandra was at risk of developing, involves the pathological growth of abnormal blood vessels beneath the retina. These vessels are fragile, they leak, and the fluid they release causes the kind of rapid central vision damage that intravitreal injections are designed to stop. The biological trigger for that abnormal vessel growth is a signaling molecule called vascular endothelial growth factor, or VEGF. And one of the most consistent upstream drivers of elevated VEGF in retinal tissue is chronic systemic inflammation. Sandra's diet was pro-inflammatory, not because it contained anything obviously harmful, but because it was structured in a way that created a sustained inflammatory environment. The refined seed oils elevated her omega-6 load. The absence of fatty fish meant her omega-3 intake was negligible. The low vegetable intake meant her polyphenol and antioxidant reserves were insufficient to counter the oxidative stress that feeds inflammation. I added wild salmon twice per week, walnuts daily, and a significant increase in dark leafy greens cooked in olive oil. Each of these changes addressed a specific component of the inflammatory picture her diet was creating. The fourth change was one Sandra initially resisted, and I want to tell you why I insisted on it. I asked her to eliminate the 2 glasses of wine she had been drinking most evenings. Not permanently, and not because of a general moral position on alcohol, but because research published in JAMA Ophthalmology has found that regular alcohol consumption, even at moderate levels, is associated with increased oxidative stress in retinal tissue and a higher risk of AMD progression, specifically in individuals who are already showing early macular changes. Sandra was in exactly that category. She was not drinking excessively by conventional standards. She was drinking in a way that was adding oxidative burden to a tissue that was already under pressure. The marginal inflammatory and oxidative cost of those 2 glasses per evening was not inconsequential in her specific situation. She eliminated them for the 3 months leading to her follow-up. She told me later it was the change she found hardest to make, and the one she was most glad she made. 3 months later, Sandra went back to her ophthalmologist. She had been consistent. Not perfectly consistent. She had missed a few days of the goji berries during a trip to visit her daughter, and there had been 1 week where the salmon did not make it into the shopping cart. But consistent in the way that real life allows for, which means reliably, most of the time, with the overall dietary pattern firmly in place across the full 12 weeks. He reviewed the new imaging alongside the imaging from her previous visit. He spent longer looking at the scans than she expected. And then he told her something she had not been prepared to hear. The abnormal vessel growth had not progressed. The early signs of neovascular activity that had been present in the previous images had stabilized. Her macular pigment optical density, which her previous measurements had shown as low, had increased measurably. He told her he wanted to see her in 6 months instead of 3. And he asked her what she had done differently. I want to pause here for a moment before I tell you what I think this means, because Sandra's reaction when I sat with her after the appointment is something I want you to understand. She cried. Not from relief alone, though there was relief. She cried because for 3 months she had been doing something every single day for her eyes, and she had not known whether it was working. She had been eating the bell peppers and soaking the goji berries and cooking the salmon and replacing the oil and going to bed every night not knowing whether any of it mattered. And then she had sat in that examination chair and watched her ophthalmologist look at the scans for longer than she expected, and heard words she had not been prepared for. I want to be precise about what this outcome means and what it does not mean. Sandra's imaging did not show reversal of the structural changes that had already occurred. Early AMD does not reverse. What it showed was a halt in the progression that her ophthalmologist had expected to continue, a stabilization that he had not predicted based on the trajectory the previous imaging suggested. Whether the dietary changes were the primary driver of that stabilization, whether other factors contributed, or whether the trajectory would have stabilized on its own regardless, none of those questions can be answered with certainty by a single patient's case. What I can tell you is that the biological mechanisms through which the changes I described would produce exactly this kind of outcome are documented, replicated, and increasingly well understood in the nutritional ophthalmology literature. And I can tell you that Sandra's case, while not a controlled clinical trial, is representative of what I have seen in patients who make these specific changes with this level of consistency. The pattern is not universal. Not every patient who follows a similar protocol achieves the same result, but the direction of the outcome, stabilization rather than progression, is consistent enough with what the research predicts that I have become far more confident recommending this approach than I was 5 years ago. Replacing pro-inflammatory fats reduces the oxidative burden on retinal tissue. Zeaxanthin directly fortifies the macular pigment at the foveal center. The antioxidant polyphenols in the added vegetables and goji berries counter the free radical activity that drives RPE cell dysfunction. The omega-3 from salmon shifts the cellular environment away from the inflammatory signaling that promotes VEGF production. Each mechanism is individually supported by evidence. Their combination, applied consistently over 3 months, produced a measurable outcome in a patient whose previous trajectory had been pointing in the opposite direction. I want to leave you with what I told Sandra at her follow-up with me after the ophthalmologist's appointment. I told her that what she had done was not magic. It was not a miracle, and it was not luck. It was biology. She had given her macula the nutritional environment it needed to do what it is designed to do when it has sufficient resources. The pathology had not disappeared, but it had stopped advancing, and in the context of a condition that can take central vision permanently, stopped advancing is one of the most meaningful outcomes there is. If you are in a situation similar to Sandra's, or if you are simply over 60 and have never had a conversation with anyone about what your diet is doing for or against the health of your macula, that conversation starts with knowing where you stand. A comprehensive dilated eye exam gives you a baseline. It tells you whether your macular pigment density is adequate, whether there are early changes present that deserve attention, and whether the trajectory of your macular health is one you want to intervene on before it becomes more difficult to influence. Most people over 60 who have that exam find they have more time and more options than they assumed. The ones who wait until symptoms are significant find the opposite. Get the baseline, know what you are working with, and then have the conversation about what your diet is doing for or against the tissue that makes your central vision possible. I want to hear from you now. Has anyone in this community been told something similar to what Sandra heard, that their eyes were heading toward intervention? Tell me in the comments. You are not alone, and your experience might be exactly what someone else here needs to read today.